Good afternoon, wherever you are. This is Michael East introducing Tim Mckinney, and we're at the ISG conference in Bari, and it's 2008. And I'm going to ask Tim, who's just given an excellent talk about vault suspension. In particular, I'm going to ask him how often he feels that this is necessary when performing hysterectomy. But first, I'm going to ask him to introduce himself in terms of where he comes from. Tim.
Okay. I have a center of excellence in laparoscopy as well as urogynecology and pelvic reconstructive surgery. I'm the director of Athena Women's Medical Health and chief of urogynecology at the University of Medicine and Dentistry, New Jersey, as well as at Drexel University. Pretty complicated, but...
I think that's the interview over, isn't it? Have we run out of time? Anyway, tell me about how often you think it's necessary to place vault suspension sutures at the time of hysterectomy.
I feel that if you have any kind of descent of the uterus, that you need to address the level 1 defect. And it's crazy to think that you're going to end up having the upper end of the vagina staying in place if there is prolapse at the time of the hysterectomy without addressing that kind of a defect. I tend to use a combination of the uterosacral ligaments from a natural approach, as well as the iliococcygeal hitch type of stitches. I tend to use a combination vaginally of both permanent as well as absorbable because of the fact that I'm trying to bury the permanent behind the vaginal wall. So the burying stitches, including the vaginal wall, are the absorbable, and I use usually a woven material of Ethibond just so it gets a little bit more of an inflammatory response at the upper end.
Do you think that even if there isn't any discernible prolapse, that we should be putting some sort of prophylactic stitch in place?
Well, if you're disconnecting the vault support structures, then absolutely you need to put something back together again. If you're performing, say, a laparoscopic hysterectomy supracervically, and there is no prolapse, the whole concept behind the doing a supracervical is to maintain all the support structures intact. There is, however, some data coming out that showing that a supracervical hysterectomy may not always be preventative. I tend to put a simple stitch utilizing the uterosacral ligaments anyway, because I usually, for my supracervical hysterectomies, close off, like Arnaud was saying in the lecture earlier, taking the pubocervical fascia and the rectovaginal septum and covering over that cervical stump. That way you're combining it in. I also like to put in the uterosacral ligaments at the same time.
Are you ever placing mesh as a laparoscopic mesh sacrocolpopexy? And if so, how do you choose what procedure you're going to do?
Okay, the idea of the sacrocolpopexy has been around for years. It's the gold standard. I utilize it, and particularly whenever I have a true apical defect, and particularly the upper 1/3 of the level 2s, as well as level 1 defects. I try to end up going for those, and yes, I do it on a regular basis. I usually use a polypropylene type 1 graft material. At this present time, I've been utilizing a new suture technique, which is called a quill. It's basically a suture that doesn't require intracorporeal or extracorporeal knot tying, because it has a property to it in which the middle of the suture from one side to the other have burrs on it that work like fish hooks. So when you pass the suture through, when you go to try to pull it back through, it will not move. So you run it in one direction and then run it back in the opposite direction, and it fixes that suture intact. It's fabulous for doing your running stitches for peritoneal closures, as well as fixation of the graft to it. probably saves me about 20 minutes to a half an hour on suturing technique.
And, thank you very much. Thank you, Tim.
Thank you.